just...
I can't now to let people in. So can someone else let people in? Amazing. And then Tommy, do you want to kick off once we feel we're quorate?
Good afternoon, everyone. Nice to see you all. Thank you for coming. We're just going to give it one more minute for others to come in, and we'll get started very soon. So hopefully you'll be able to see the slides presented at the moment. So just give it one more minute and then we'll get started. Right, let's get started. So good afternoon, everyone. Thank you for your time this afternoon. Really excited to have you here. We are here for the Social Care Interoperability Platform Stakeholder Engagement event, and we'd like to showcase some of the work that we've been doing within the Digitising Social Care programme to date. So if you could move to the next slide for me, please, and we'll just have a look at the agenda. So we would like to go through an overview of the session, which is what we're going to do now, where we're going to look at some of the strategic overview with our programme director, Peter, some of the ideas about what's been happening with our assistant director, Chris, and then some of the themes that we're hearing from our users from Will, and then we'll have a Q&A session at the end, as we do with these sorts of events. So a little bit of admin before we get started. If you have questions and you would like to post some questions for the panel, could you please put them in the Q&A? We will curate those and we will come to those at the end. So this session is being recorded, so for colleagues who aren't able to make it, we will disseminate this afterwards. And we will try and answer as many questions as possible. Those we can't, we will share our email address for you to contact us afterwards if there's something burning that we haven't been able to address within the time constraints that we have. So without further ado, I will pass to our programme director, Peter, for a strategic overview. Peter.
Great, thanks, Tommy. So I'm going to just give a quick overview of where we are now and some of the opportunities for the future as well, and try not to get too distracted by the pinging sounds as people join, which takes me back to the early days of the programme when we were doing quite a lot of very wide engagement events like this. So where we are right now is that about 80% of care providers now have a digital social care record. So these are adult social care providers that are registered with the CQC, and there's about 18,000 of them in England, working across 24,000 locations. When we started the programme post-COVID, only about 40% of those care providers had a social care record system in place. So we set up some work to provide support to people locally to help them to adopt the care records. We also set up a national approach to assuring the care record systems and ensuring they were compliant with key standards that would support interoperability and data sharing in future. And we published a minimum operational data standard for social care as well, so that when that is adopted by all of those care providers, we'll be able to capture and share data in a quite consistent way across the different providers, because we know multiple providers are often involved in delivering an individual's care. We also know that there are huge opportunities to make sure that data can flow much more smoothly between the health and social care sector, particularly when there's changes in a care environment for a person. So, for example, if they're admitted into hospital or if they're having regular GP visits. I won't talk too much about that, though, because that fundamentally is the purpose of today's session, is to update you on some of the work around that. So I will leave that to other presenters to cover. We've also been building up a stronger evidence base for the impact that different types of care technology have on people as well. So these care technologies that support people to live independently in their own homes for longer, help to reduce demand for social care services, and also help to reduce demand on health services as well. So, for example, falls prevention and detection technologies that reduce the number of people that are conveyed to hospital and require admission post-fall. And the figures vary on that depending on the care home, and we're still doing some of the evaluation of the evidence, but they appear to be able to cut falls between 30 and 70% from a care home, and falls are the number one driver for hospital admissions from social care. So if we move on to the next slide, that's where we are right now. Where we want to get to over the next few years is that we have a much more digitally mature social care sector that is much more connected and is making use of care technology as part of a routine package of care. So the government announced back in January last year, 3rd of January last year, so we've passed and frankly missed the anniversary for that, alongside that they were going to launch the Casey Commission, which is looking at what needs to be done to allow for the creation of a national care service. And that's an ambition that the government set out in their manifesto, that they wanted to have a plan in place by the end of this parliament so that if they are re-elected, they would be able to introduce national care service in the next parliament. They also announced at the same time I think 5 key objectives, of which 3 are most relevant to us and are the ones that are on the slide here. So first of all, that we would introduce new national standards for care technologies. So those evidence-based technologies that, as I said, we know can support people to live independently for longer. How can we help people to make sure that they are buying technologies that they know are going to support them and that are fit for purpose? So whether that buyer is a commissioner or a local authority commissioner or an NHS commissioner, or whether it's a family member or an individual that wants to keep themselves safer in their home for longer. Right now, it's very difficult to work out what is going to be useful and effective for you, and the idea is just to try and make that a bit simpler. Second area, and I've realised as I'm speaking that I should have reordered these because I'm going to jump straight to fully digitised and then come back to joining up data because it's a much better segue. Second area is that all care providers will be fully digitised, and this is an ambition that was set out that by the end of this parliament, all care providers will have an assured digital social care record in place, so one of those systems that's compliant with standards, and that they will have achieved DSPT standards met, so Data Services Protection Toolkit. So the idea there is that we can then make sure that we are able to capture and share data much more consistently. And that was recently reconfirmed, so that was there was an announcement on the 5th of December that confirmed that position. And that's really important because it means that we'll have the solid digital infrastructure in place to help us to completely redesign the way in which people receive care, make sure that they are receiving care that is fit for purpose and most suitable for them, but also make sure that we have the necessary information flows that we're going to need if there is a national care service in future. And last but not least, or second on this slide, there was a commitment around joining up data for care. So linking up the existing social care data with the NHS more effectively. That's where the work on the interoperability platform comes in. But really our ambition here is to make sure that you're not having to repeat data and information about yourself multiple times. People are able to see the same information about you. And critically, if we're thinking about the 10-year plan commitments around things like neighbourhood health, how can we have a neighbourhood health team operating if it doesn't know what care is being provided to an individual? We need that information to be available, and we need to not create huge mechanisms for capturing that. It needs to just be generated as a bit of a byproduct of provision of care, and we need to make sure that's done as smoothly and efficiently as possible so as not to add burden onto the front line. Similarly, if we want to start looking at things like population health management, understanding what's actually going on in the social care sector, who is using social care, when they are then interacting with the NHS, and therefore where can we intervene to either reduce demand in social care by putting in place an intervention on the NHS side, or reducing demand on the NHS by intervening on the social care side. All of those things need us to have a properly connected data architecture, and all of those things give us enormous potential for fundamentally transforming care in the future. But a lot of that transformation has to happen locally. Our role is to do what we can nationally to enable that information to flow, to make it available to you, and to make it as easy as possible for people on the ground to rethink how they deliver services. So I'm going to hand over to Chris at this point to talk about the work that we've been doing so far on the interoperability platform and to provide a quick summary of what it actually is as well.
Thanks so much, Peter. Hi, everyone. Really Glad to speak to you today. So my name's Chris Elkington. I'm the Assistant Director in Digitising Social Care, and I'm running that JUD, that joining up data aspect that Peter just talked about. I want to zoom in a little bit more from that kind of strategic aim, that strategic direction, into what we're doing right now. So because this is quite a wide event, we'll have some people that have heard of SKIP, the social care interoperability platform, before, and other people that are just joining, wanting to know what's going on. So I'll try and give a bit of cover and talk about exactly what we're doing and the direction we're going. So the emerging problems that we're finding right now, as Peter mentioned, so DISC phase 1, 5 years of work, we've done a fantastic job and they've managed to digitise about 80% of care homes. So that's pat on the back, well done. But as we're finding right now, data's not currently joined up across care and definitely not between health and care. So this is leading to a number of problems. I've got them listed here. So we've got fragmented systems in adult social care. Data exists in 18,000 places approximately, and data's not fully standardized. So we have recently released something called MODS, the minimum operational data set. When we say data's not fully standardized, the concept in health that a lot of people will be familiar with of ISNs and data standards. There are commissioning data sets that cover absolutely everything, and then there are specific things. That kind of concept and that ecosystem doesn't really exist across the care sector. So we're making a good first stab with releasing MODS, but still the data's not fully standardized in order to be interoperable. We don't have a central national view of the data, and data across the sector and between health and care, it's not joined up. So the impact of this, you know, to citizens, to people like ourselves, is that there's discontinuity between health and care. And this can lead to unnecessary hospital admissions, delays in discharge and things like that. In our work to digitise social care over the past 5 years, we've had an amazing push, but now that we've got these suppliers, these digital social care record, DSCR suppliers, we've got a list. It is assured, but each of the suppliers have been approached by each of the 42 regional shared care records. They've been approached by different areas of the NHS. They've been approached by different interoperability services, and it's just become kind of untenable really for point-to-point integrations to happen. We've digitized them, created them, but one example we were given was that a digital social care record supplier did one link up with a shared care record, and the amount of assurance that it took, you know, from health processes and just the bringing on the additional staff that they weren't used to having, it cost, you know, circa 40 grand and took nearly 2 years. Now, if that has to happen 160 times for each of the 42 across each of the people on our assured suppliers list, that's an awful lot of public money and an awful lot of time that will be spent trying to do things. And there were additional things on top of that. So getting access to HSCN, so Health's virtual private network, costs money. There is plans to make it internet open, but for now they've had to spend money, and across the care sector 10 grand means an awful lot more than it does across health, so that's quite a big chunk. And we know that there's a lot of talk at the minute about things like the Federated Data Platform, FDP, the Single Patient Record, SPR, things like that, and these will all require additional integrations. So that's paint the horrible picture, the emerging problems that we've got, but we've got a hypothesis that having a single point of consolidation, so that each of the areas of care can just connect up to that, and then each of the areas of health can just connect up to that, and we can manage it, will reduce that interop burden and increase security. Can move to the next slide, please, Steph. So we don't plan to solve all of these problems from day one and everything. We've got a hypothesis that having something called SKIP, this social care interoperability platform, can help with that. The big green box on the right, 1st of Jan last year, the Secretary of State made an announcement that there would be a thing called SKIP that will be by April this year. So that's the wording that was in there. But
sorry to interrupt you there, Chris. You froze at a critical point between Secretary of State's announcement and what that would be by April.
Thank you very much. Everybody loves tech. I'll try not to move as much so that Wi-Fi doesn't cut out. So yeah, on the 1st of April, there will be the first iteration of a social care interoperability platform. So that's a Secretary of State announcement. That's a ministerial commitment that's been made and has been really good for us in terms of prioritisation, freeing up funding in times of a lot of change in NHS England and DHSC. So that mandate wording is on the right, but the plan is that we want to create a platform akin to the spine in health, which will facilitate data sharing across health and care. I won't read out all the words on the slides because you can read it for yourself, but the plan is to be able to give people access to the information that they need. And our first priority is discovery. So we're doing stakeholder engagement, user research and technical work to check whether Skip is viable and what form it can take. Steph, if we could go to the next slide, please. So why does Skip matter? So we want to take an approach of user-centered care. So within care, people have personalised care plans. We want that to be supported and travel across care into health, rather than everything having to be repeated as you move from one sector to the other. And then the same going back out again as you leave hospital. We want that information to be available to care workers. That should reduce clinical risks and risks across care as well. And health and care staff having access to real-time information will be able mean that they can give much more personalised, person-centred care. Because we are public sector and we have to do business cases and things like that, of course this will lead to efficiency and cost reduction, but that is not a name in itself. That just means that we're able to put ticks in boxes and pay the bills. Over time, that will lead us to enhanced data supported insights. So at the minute, there is an awful lot of data that flows around health and that is analysed and gives amazing insights. But people that don't touch health as much and the full range of everything, linking care to data will allow for so much more analysis. And again, strategic alignment, working in tandem between health and care on the ground, multidisciplinary teams, they all work together very closely. It sometimes doesn't happen as much at a strategic level. So they're the things that we want to do, all really high and lauded aspirations, I'm sure you'll agree. But one of the important things about a platform is what it's not. So are keen to point out at the start. So we are not in the business of trying to replace the functionality of digital social care records. So we've put, as I keep saying, the last 5 years into creating, these markets to getting suppliers on a list. We don't want to replace their functionality. We just want to allow them to be able to talk to each other and talk to health and interoperate. We plan to, first of all, to have use cases for direct care. So without further work on a data storage solution, we're not going to create a big data store here, a big data warehouse, and start stripping everybody's data. This is about the interoperability functionality, standardizing and allowing systems to talk to each other. We do plan to have a separate discovery next year on once Skip exists and all of the suppliers are able to talk to each other, how then might we be able to start looking at secondary uses and pooling and things like that. But for a start, we just want to sort out the interoperability side of things. So on top of that, if we've not got a data store, we're not planning to provide an analytics platform for care workers to manage their services. At this point in time, there may not even be a front end. We expect suppliers to do those types of things. So this isn't something that we go on and Skip would be useful in order to manage your service. It's more something that is back end and makes it a lot easier for systems to talk to each other. We can move on to the next slide, please, Steph. So and apologies for people that aren't very agile, but I want to talk a little bit about our approach, because when I start talking about Skip, most people come to me and say, right, great, when's it going to be? Insert their area of when they work. When are we going to do local authorities? When are we going to do care homes? When are we going to do children's? When are we going to link with single patient record and FTP. So right at the very start of the program, we don't have an answer to those things. The way that product development usually works, 10 years ago back in the day, was that you would come along, a minister usually would have an idea, say, we want to create this, make me an app, build an extension to a house, develop a booking system. And so you'd go out, you'd get lots of business analysts and things, and you'd develop lots of documentation, do lots of design work. So that is going from the start up those big red lines, you generate a whole lot of stuff. And then after that, all that code, the training, everything would be brought together into one product. And this is not an error on the slide. As you can see, it all looks a bit odd. So we tried to do something and we've ended up kind of not very aligned and not very there. Even though the work was all very good, we've ended up with an end product that hasn't really hit the mark. If we could go to the next slide, please, Steph. So one of the things that user-centered design people like to bang on a lot about is the double diamond. So this means that before we even get to the start of this middle bit, we go right back to the left. So we take that original idea, that mandate. As I said, we've got a hypothesis that an interoperability platform may help. So we go out and we do a whole load of user research. We speak to people that are working in the area that we're talking about. We look at the systems that are already being designed in operation, what people are using, what they're not using. So we do a whole load of this user research and gather a ton of information. And then we spend time analysing that and bringing that back to what is the problem statement here. Maybe we don't need a new app. There are existing apps that are there, but it just needs a tweak in order for people to be able to know about it. Maybe it's not one new system that you need. It's a whole load of different tactical fixes. So things like that, and then you know what you're actually doing and you can start developing it. So where we are right now, we've done pretty much done the first section of discovery. There's a few bits left to finalize, and then we're going to start bringing everything together and prototyping and seeing if what we want to produce is viable. Obviously, health and care, massive big sectors, and it may be that it's just too big a job and that the market's too complicated, or the IG is too complicated, or anything like this. It might not be viable. So we're going out discovering all these things, and then we're bringing it together. If we could go to the next slide, please, Steph. Our approach for how we do this is, that old adage, how do you eat an elephant? One bite at a time. So we are not planning to do that old school waterfall thing of there is an idea, we will write a business case for 3 years in the public sector, then we'll spend 4 years developing it, and maybe after a decade we'll throw the door open on a fully fledged system and it will no longer be relevant. We want to get something done quite quickly, so it was September we started work on this, and we're planning to prototype and have something ready for that ministerial commitment of April, and then we plan to do something with just very high level use cases, get that out and develop the system and increase the scope as we go along. So we'll start small, deliver things iteratively, so that we're not trying to crack all those things like secondary uses of all of care data, how you control data usage across 2 different sectors and between. What we want to do is start very quick and do things iteratively. If we could move to the next slide, please, Steph. Because we're working in the public sector, one of the things we need to do is follow something called the service standard. So we have to go through discovery phases, user research, technical analysis, and go through various gateways. So we have to move to alpha and then private beta and public beta after that. So we one of the things that has been analysed recently is that the first gateway is after alpha. So you need to have done discovery, have built something, you go with your alpha assessment, and in around about 90% of all reviews that happen in the public sector, they say that's a fantastic alpha, but you failed because we don't like what you did in discovery, you didn't speak to enough people. So we've piloted with GDS the idea of a discovery review. So we spoke to them. It was only the second one that they ever did, but we've done a little bit of a check-in, and they're pretty happy with how our discovery is going. With just a few more things that I keep referring to as the chef's kiss that we can add to the top of all of this analysis. So going out and speaking to a few more people. So we're going through those gateways, and that's how we're going to develop the system. Could go to the next slide, please, Steph. Again, as I've said, rather than having a plan and saying here's the scope, this is when we're going to do local authorities, what we want to do is have this idea of a roadmap. So a roadmap, you kind of, if you're going on a long journey, you know where you want to get to. You're not necessarily sure what roads you're going to take. There's going to be closures and traffic jams, and you might have to divert. So you kind of know right now whereabouts you're going next, and then things get more vague as you move into the distance. So I've made this very bold, indicative. Now, I've been encouraged by loads of people to develop a roadmap at the start, because we've not done discovery. We've not had agreement that this is viable and this can start, and what our first use cases should be. I can't show the real roadmap. That'll be something we develop over the next few months. But here's what one might look like. So I've put indicative there, I've made it very bold so that people don't start quoting it in totality. But the type of thing we may do. We're working in adult social care. You know, that is the thing we want to do. We don't want to take health and then run rampage over the care sector and say you must use these products that have been from them. We're about the business of adult social care. So we want to start with connecting care systems together. We've done a lot of work and spent a lot of money creating this market for DSCR. So getting them to be able to speak to each other, that seems like a very sensible first step. And then because the health sector is very mature and has a lot of systems and things out there, getting a feed from health and making that available to care seems like a sensible next step. Once this mods data set that we've talked about, once we've got standardized data, we've got it all flowing together, it would then seem really sensible to be able to feed that back over into health so that they can start working together. Once we've got a system which is up, which is deployed, which people have got trust in, we know is working, then it would seem sensible to deploy tools over that, like we've got various services that sit on the spine. So things like risk stratification and utilizing AI. We know lots of local authorities at the minute a bit buying AI tools, but the things they're saying to us is we're having to do that options analysis ourselves. We're having to buy something. We're not really sure if it's good, if it's the best thing. And there's a big request for centrally us to be able to either deploy that once over everybody or recommend tools. So those types of things would be really useful. And again, most people on this call that have known me for a while, I recognise a few names, will know that I worked on child protection information sharing, CPIS. So children's social care is really important to me. So I've been saying to people for over a decade, I will hook up adult social care and children's social care, and we will connect everything to health. So this has the potential to be able to hook up to other sectors. Housing is such a massive effect on care that being able to connect to other agencies and people's apps and things that they buy, being able to hook up to them would be a fantastic aim. So this is the type of thing that we'd like to be able to move to. Could we move to the next slide, please? Thank you very much. So just to put a little bit more meat on the bones, the types of things that we would be thinking of covering, the types of use cases in SCIP will be things like streamlining hospital discharge processes. So being able to get the notes and get them into care homes to be able to make things much more seamless and quicker for patients who have to repeat a lot of their information every time they move. Vulnerable individuals, being able to flag high-risk patients and be able to get that information out to crisis teams and ambulances and give that information for vulnerable people would be hugely beneficial. When somebody gets admitted to A&E, you know, you're just a person, just an NHS number, you don't know from Adam until you hit the ground, and then they find out, you know, you have autism, you have disability, you have mental health issues. So knowing that in advance, hugely useful on the ground. Predictive analysis and resource planning, those types of trend analysis and things, the more we can hook across sectors, that will lead to absolutely huge benefits. We all know that budgets are tight and everything's being squeezed more and more, so those types of planning and analytics are really useful. Safeguarding and risk management, again, if we know about safeguarding concerns and are able to share those across agencies, we'll be able to stop patterns of behaviour by abusers and be able to identify them and move in and make sure that people are more protected. Eligibility checks and things, people having to repeat lots of care information for DWP and all those types of bits. Knowing information about care can make a lot of these assessments and eligibility checks a lot easier. Financial and administrative processes, again, because budgets are tight and people are working on the ground much closer together, there's not an awful lot of delegated healthcare activity that's being done by care, and there's perverse incentives whereby care might have to do the work, but they won't necessarily be funded by it, even though they're most appropriate. So being able to identify which activity is done and be able to build that back will be hugely beneficial. And then obviously user-centered design. Service users, I know I've got a disabled son myself, and having to repeat his needs every time we go into a health setting is takes up a lot of time, and it's quite frustrating. Having that automatically available would just make life so much easier for people. And then if we could go to my last slide, please, Steph. One of the other things that this is really important for is to enable a lot of things that policy has been trying to move towards over the past decade. So being able to work closely between health and care. There was a Health and Care Act, but my experience has been that most of it has just been, let's do a find and replace on health and write health and care. There hasn't been a huge amount of work actually in care of doing things. So having an interoperability platform and being able to connect between the two sectors, that will be an enabler for things like the single patient record. So getting a feed from care and getting the information in actually makes that real. Health is trying to move a lot more now into neighbourhood, which does mean community, which does mean care. But again, it's coming from a very health specific background. So being able to get these systems hooked up will be a huge enabler to that. I've visioned for the NHS app that it could be the NHS and Care app. People that they have their parents, their grandparents in care homes, being able to manage that information. It's very good that we can manage our own care now and appointments and test results through the app, but being able to see the information for people that we care for would be huge as well. Local authorities, although they are much more digital and interoperable than DSCRs at the minute, there is a lot of dual coding and duplication that has to be done, manually sending information to DH and manually sending information across to health. So we'd love to be able to reduce that data burden to be able to automate it. There are new things being set up, the HDRS, Health Data Research Service. There is, through DARS, there's a lot of information that you can get from secondary care, which has been useful for analytics, and everybody's always after GP because that's so much more richer. When analysts get to hear about care and knowing, there is information about people's mood, how often they eat, what they eat, how they feel. That richness of data has such huge potential in analytics and big data. And then lastly, National Data Library, being able to get all this information, bring it together. So all these things could be made possible by having a social care interoperability platform. Right, that's what we want to do. Very quick overview. Hopefully it's been useful. But as I say, we've been doing a discovery exercise, and I want to hand over now to Will to talk a little bit about what we've been hearing during that user research phase. Thanks, Will.
Thanks very much, Chris. So afternoon, everyone. I'm Will Hemingway, the product manager on Skip, and I'll be providing a bit of an overview on what our research thus far has entailed and what exactly we've learned. So the first half of the discovery phase from September to December of last year consisted of 3 distinct strands of research, that being user, technical and governance. Within the user research strand, we wanted to understand who our users are, their needs, and current approaches to accessing and sharing data. We used surveys, interviews, observations, and desk-based research to achieve this goal, and due to time constraints, we narrowed our focus to people working in specific care environments. So those included residential, nursing, supported living, and domiciliary care settings. So on the technical front, we wanted to investigate and evaluate digital solutions and architectures which currently exist in the space, with the goal of understanding what the current capabilities actually are. So we undertook desk-based research there, as well as interviews with digital social care record suppliers and specific national programs like Federated Data Platform and Single Patient Record. The overarching question we wanted to answer was whether interoperability was actually achievable in this sector and what the future requirements could be. And then finally, our governance research looked to answer what legal basis currently exists for sharing data, including any controls and differences between health and care data, if in fact there are any at all, alongside role-based access control requirements. So activities in this space also included desk-based research and interviews with local and national colleagues with experience sharing data across organisationally, such as local authorities. So our focus was on direct care as part of these discussions, given enhancing data for the purposes of direct care is the initial driver for this work. And secondary use is something that we may consider over the longer term, but is not within scope at this moment in time. So just to reiterate, discovery at this stage is not about designing or delivering a solution. We've been evidence gathering, researching and feasibility testing to determine whether an alpha actually should proceed and in what form. Next slide, please, Steph. Thank you. So the findings have been exceptionally insightful and have identified a practical operational need for an interoperability solution in adult social care. I had the pleasure of attending quite a few of the interviews over the previous months, and it really did bring to life some of the value of this work, which is great. So through over 40 interviews in total and numerous survey responses, the blended team analysed and distilled these learnings into 4 primary use cases to carry forward in the first instance. Those use cases are transfer of care between settings. So we heard consistently that poor communication and a lack of data exchange through the admissions and discharge processes is something which needs addressing. So this prompts opportunities for us around enabling real-time updates and automated notifications through a solution to improve coordination and visibility. Transfer of care between providers, which is also a significant issue. There is a risk of broken continuity of care and system supplier lock-in caused by technical and commercial barriers, despite data migration standards being in place for assured digital social care records. So there's an opportunity here for an interoperability solution to enable seamless transfer of information for individuals moving between care settings, but also care providers changing systems, maintaining that vibrant digital social care record market I mentioned earlier that we've built over the last few years. So also considering the vulnerability of those in receipt of care, multi-agency interventions are extremely common in adult social care, and users noted a distinct lack of visibility in terms of appointments involving those agencies which are separate to the care provider. So think nursing visits, GP appointments, ambulance conveyancing, among others, who all use their own systems, and the information they actually store is not necessarily made available in the care provider systems, which creates a very distinct disconnect. The opportunity here is to increase that visibility and continuity of care through a solution which can create the connections to consolidate that kind of information. And finally, NHS number coverage is a significant issue in this space. Due to manual error or simply not being entered into the record, individual matching is made difficult for services like GP Connect and hinders future linkages with other parts of the health and care system. Developing a solution which can support in kind of ensuring that NHS number is there and available with some kind of validation functionality is also an opportunity for us through this work. So the ordering is a little strange on the slide, but it's intentional, as those particularly marked are the 2 use cases that we're starting with to test through in the next statement of works period that we're undertaking. So this particular phase now, from now until the end of March, will involve further research activities as well as drawing up proof of concept to assess the viability of developing the connections which would make those use cases possible. So just to clarify, those use cases are transfer of care between settings and NHS number coverage and matching. Next slide, please. So at the end of December, the first phase of discovery was completed, and through engagement with government digital services and a bit of a distillation of what we had learned, we were faced with kind of what should be prioritised for the second phase of discovery, which takes us through to March. So the strategic paths that are listed here reflect the options that were available to us, and ultimately the decision to reuse the reuse of existing components to validate our learnings through testing a proof of concept prior to moving into that kind of alpha development was determined to be the most valuable course of action. So this particular decision was made to balance value for money with the ability to decouple any of our explorations and findings and use any componentry beyond the life of this contract, not being kind of confined to any solution at this stage. So we expect the outcomes of this work to help inform a future procurement, a future project, which will focus on actually developing an alpha solution, which we can then kind of look to move further along in that kind of development process. As far as next steps for this particular phase in terms of specific activities, we have begun, and our primary goal is to create that proof of concept using the priority use cases outlined and test it with stakeholders, and also expand our user research in line with what government digital services recommended, defining the data transfer data set. So many of you will come across the minimum operational data set, otherwise known as MODS, and exploring exactly how that can work in relation to what a solution could look like, and also explore what the architecture behind a prospective platform could also look like as well. And without going into too much detail, that is where we're at the moment. Thank you.
Excellent. Thank you, Will. As ever with show and tells, there's lots of information and lots to digest. So we will go to questions to the panel. So our first question is from Anne-Marie. Hello, Anne-Marie. Nice to have you on the call. So Anne-Marie is asking a question around the relationship between SCIP and HDRS, which is the Health Data Research Service. So if I may, Chris, can I pass that your way firstly?
Yes,
please?
Of course. So we have had conversations with the HDRS service as to how all these things might work. I mentioned right at the very start in the what is SCIP not, if that's not terrible English. So we're starting out with a direct care use case, as Will's talked about. So people on the ground, they need information in order to be able to care for people. So if this was a clinical system, then they would be able to have access to the information they need. That makes things like the IG legal basis a lot easier. And because we want to get up running and not take 10 years to get this out of the door, that seems like the most sensible, best value for money way to go about it. That means that secondary uses and being able to move it on is something that will follow later. So we want to get direct care, get it proven, and then we'll start to look into big national consultation about taking private people's public data and being able to pull that together and share it across different sectors. At the minute, of course, there isn't a national care service. So there is a national health service. We pay for that. That gives it a lot of legal basis, means you're able to gather a lot of data. Without a national care service, that isn't there. So the roadmap would say once we've done direct care, we'll then look at establishing the legal basis, the IG basis, doing big national consultations, and then if we can establish the need and get approvals for secondary uses for the data, we'll bring that together either in a future iteration of MODS or something like a new data set, like a reporting minimum data set, those types of things. Bring that together, and then that is the feed that would be used to go into single patient record, to go to HDRS or things like that. So long-winded way of answering, but that's our plan for secondary uses and being able to feed information into analytics and things like that. Is that all right, Tommy?
Yeah, super. And I think you mentioned the phrase, but in terms of Charlotte's question, is the timeline 10 years? Your response to that?
I would hope that it's still going to be here in 10 years. I think the current iteration of Spine is about 12 years. I seem to remember 2014 was when we brought it in-house. So the plan is that this is going to be a key piece of architecture for the National Care Service. So if it's there, it should still be around in that time. But we don't expect it to go live in 10 years' time. We'd like to be able to get something out and touching the ground in around about a year. As I said, we're going to prototype, take this ministerial commitment by April, but then turning it into something that is going to affect people's lives, clinical data is going to go through, is a big step up. So it'll take a little bit longer than 14 weeks that we're going to spend developing the first bit. So yes, I expect there to be a 10-year timeline to bring on things like secondary uses, but the direct care timeline is going to be an awful lot quicker than that.
Okay, great, thank you. Can I pass the question from Paul about GP Connector to you, Peter?
Yes, and just also very quickly to pick up on that time frame point, I think Chris talked earlier about the iterative approach that we're taking. This isn't about us trying to fix everything and only releasing something into the wild once it's quote unquote completed. We want to make sure we're releasing something and then we're building on that over that period of time. I think the reality is that in 10 years, we will hopefully have achieved everything that has been set out, plus some other things that we haven't thought of yet. But I'd also expect us to then have a whole load of other things that are on the agenda as new areas that we want to explore, or potentially areas that we think there's a different approach to as well. So just to reassure you that it's not going to be a case of radio silence for a prolonged period and then we suddenly pop up with something that we've built. So on Paul's point, the short answer to this is yes, and the longer answer is yes, but. So we know that there's some discharge information that could be captured through GP Connect. We're very keen to move it to the structured view for GP Connect if we can as well. But we also know that there are some challenges with the way in which that data is currently uploaded into the GP system. So it's not always consistently available from hospitals at the time at which the care providers would need it. And this is one of those areas where we may well find that the barriers are not technical, but are actually operational. Because the thing is that if you're a care provider, and I'll give you a personal story here. My grandmother was in hospital on a Sunday afternoon. My dad and I were in with her because she'd been told she was going to be discharged that afternoon. So we were going to take her back to the care home and make sure she settled in. We spent a few hours with her and then somebody came around and said, oh no, she's definitely not going to be discharged today. So it's the end of visiting time as well. So we headed off and each of us went back to our respective homes. And my dad contacted the care home to let them know that she wouldn't be in that afternoon. And they said, oh, well, an ambulance has just turned up with her. And fortunately, we have enough staff on, so we were able to take her in. That could easily have been that could have been a failed discharge because they could easily have not had the staff on Sunday afternoon with the necessary ratio to support her. There could have been changes in her needs that would have meant the care home wasn't able to accept her that afternoon. That could all have been avoided if the data was available, but it has to be available live. And often discharge data isn't currently available until the next day via GP Connect. So yes, but there may be other things and maybe other solutions that we need to put in place or other things that we need to do in order to make sure that data can be shared.
Can I ask you a question, Peter, just in relation to the government's commitments around adult social care at the moment tend to look or talk about national care service, fair pay agreement, and delegated healthcare. How do you envisage this work feeding into that work, particularly around the data and activity?
I think one of my main reflections on a lot of the ambitions at the moment are that you need a lot of data available if you want to avoid having to create a large regulatory and oversight structure in order to support them. And so I would see a lot of the things that we're doing here as absolutely critical to making sure that we have the necessary information available for people to make decisions and that we have the information available to people to design a national care service in a different way to the way in which the NHS was designed. And it's very easy to forget that when the NHS, I say very easy to forget, possibly isn't easy to forget, but it's perhaps worth reflecting that when the NHS was set up, computers were, well, they were around, technically speaking. They occupied huge rooms and they weren't commercially available, and they certainly weren't ubiquitous in the way in which they are. And so if you were designing a health service from scratch now, or a national health service from scratch now, you would embed a lot more technology from the start. You would embed a lot more data and passive monitoring from the start. And I think there's an opportunity for us to make sure that the thinking on National Care Service is doing that, and is making use of as much data that we've already got as possible. I don't know actually if I've answered your question there, Tommy. I may have just got off a little bit of a hobby horse of my own about making sure that we design something that properly embeds digital rather than seeing it's nice to have add-on at the end. But I do see this as absolutely critical to doing to actually building a successful national care service without creating a large infrastructure around it to to make sure that it works effectively.
I mean, that satisfies me, but I think there's a question for everyone, because I think it's quite interesting when you sort of exponentially think about what our activity could look like. So there's 2 additional questions that have come through. First one from Claire, if I can pass that one to you, Chris, and then the second one from Anne-Marie again around the around mods confined to commissioning for state-funded care and care packages. That's quite an interesting question. So again, Peter, if I could prep you for that one. So firstly, Chris, could you what's your thoughts to Claire's question around the consideration to linking records for professionals oversight, i.e. the full picture to carers, cared for children? You alluded to that a little bit in your section.
Yeah, good question, Claire. So I know you know this, but for everybody else's benefit, we talk about adult social care here, ASC. So there is a separation of responsibility across government. So children kind of become adults, but Department for Education, DFE, have responsibility for children's social care, and then adult social care is the responsibility of DHSC. So the sector that we're working in right now, what we're developing this for, is adult social care. But we've been working really closely with DFE. The case management systems that they use are there's a bit of a duopoly going on, and they don't get updated as much as things in health. So they're looking at what can they do in terms of standardizing data, what can they do in terms of interoperability. What a surprise, that's kind of what the entire sector and everybody's looking at. So we're very keen to come together. So they'll take a standards-based approach. We'll take a standards-based approach because it means hooking data across DFE and across health. That's going to be quite complicated, and because the way Spine works is it's person-centered. There's not necessarily a familial link there. So when a lady is pregnant and she has a child, there's a link there. But once that other person has an NHS number and done that, there isn't necessarily something that says these 6 people all live together and are related. But that's something that would be massively helpful in terms of carers and cared for children and bits like that. So it's something that is a use case. It sits there on the roadmap, but it's also in the very complicated pile. So in terms of our priority use cases, you know, we do things in terms of now, next, later. It's kind of sitting on the backlog in the later pile to go. We're discussing it with DFE, and we're not entirely sure how we're going to bring it together. But yeah, it's really insightful question and something that will have huge benefits when we get to it. Thanks, Tommy.
That is very helpful, thank you. So some more questions coming in, which is fantastic. So first question from Anne-Marie around mods. Peter, can I pass that to you? And then Will, would you be happy to comment on Kate's question around the single patient record?
Yes, so on mods, the mods is a data standard that's targeted at direct care. I'm going to say 99% because I'm not absolutely 100%, but 99% sure that we don't capture finance data in mods, and we'll issue a correction after this if it turns out that we do. But I can see I've got a thumbs up from Alison, who led the work on the mods, which suggests that I'm right. So I'm going to say that we don't capture finance data in mods. But if it turns out we do, then I will confirm the response and correct my position on that. But as I say, 99% sure that it's not there. I'll also just drop in as a response to that question, the link to the mods standard itself that shows the data fields that we do capture within it and that are the definitions of each of those data standards as well.
Thank you. So we've got 5 minutes to go. So if you do have a burning question, do feel free to put it in the Q&A section. So Kate, hello Kate, nice to see you. Question around, it's a very good question. Does this render shared care records obsolete? Do
you want me to jump in on that one? I'm going 5 minutes left. Let's get it nice and quick. So I don't think so at all. We've been working with the shared cared records. So they've got front ends. They've been, since like 2017, they've been working really hard on creating ecosystems that are able to bring data together, link it, and give people visibility for that. They've been really struggling with care, so it's been taking a long time for them to get into care homes and move things. So the things that we're talking about with them is if they're hooked up to Skip in the background, then that would give them huge benefits if they were able to get data from Skip. It's just a piece of middleware that sits there. It's really data from DSCR providers, so data from 18,000 different care homes that gets plugged into a shared cared record. It absolutely supercharges it. So I think rather than making it obsolete, we're really keen to work with them. Why would we create front ends and do all these linkages when they've been spending years doing that themselves? And again, SPR, single patient record, that's really in its infancy as well, so it's not too sure whether it's going to be a system on its own or it's going to hook up existing ones or things like that. But what we've talked about is if we can bring data together, if we can get mods data, if we can get it agreed for secondary uses, then we can have an API that is, here is care data, and that's something that would be available to shared cared records and available to single patient record. But all of these types of things, because we have to do service standard, because we have to go through clinical safety, we have to go through assurance, all these things, building in safety and security and privacy by design is absolutely essential for what we're going to do. So none of this would happen just automatically. There's a great big load of work that need to go into who we could share data with and what for. The shared cared records are a lot easier because again they're direct care use cases. It's when we get into secondary care use cases, so things like the single patient record and FTP and all of those types of things that people get much more nervous about. That's going to be back end of that roadmap that I keep referring to and take a long time before we're able to move in with it. Is that right, Tommy?
And Will,
I keep saying you as if you're asking the questions.
Yeah, well, vicariously.
Is that okay?
It was just to add on as well, like from the very beginning of this process, we've been working with national NHS England architecture colleagues on developing all the work that we've been doing. So following the same kind of principles. So when it comes to whatever solution a single patient record ends up being, the intention is we've been running in parallel, so we're quite easily able to join up wherever that is possible and feasible to do so. So we will keep those relationships going, and the intention is not to build anything in a silo.
Very important point, and how much do we see of that? So thank you, everybody. Any more questions? We've got 2 minutes. No. Thank you, everyone, for your time. Thank you for your attendance, and please keep in touch and keep an eye out for some further show and tells throughout the year as we continue this work. And hope you're all well. Stay safe, and thanks again for coming.
Thanks, everybody. Cheers.
Thank you.
Thanks all.